presentation of Trouble Removing the Kid Glove, Strategies for Implementation of High-Intensity Training in Neurologic and Geriatric Populations. I am going to start this project, and I'm going to talk about implementation of high-intensity gait training, identifying the initial strategies and the research and clinical applications, primarily in patients with stroke and spinal cord injury. Jenny Moore will then talk about barriers and facilitators for promoting high-intensity training at an organizational level. And Margaret Danilovich will talk about strategies for implementation in the home and nursing facility. Carrie Holloran will then follow up with strategies for implementation in inpatient and outpatient neurologic rehabilitation settings. And this is a follow-up to a project that we did last CSM, also titled Removing Kid Gloves. This is more of an application-based CSM presentation where we try to give you hints, tips to apply it in your real-world situation. All right, so just to refresh the principles of rehabilitation, everyone knows these. What we focus on in our studies are three of them. These three: specificity, repetition, intensity. That is, what you do matters, how much you do matters, and how hard you do it matters. And so we have tried to apply these in different research settings, but as a comparison, traditional physical therapy practice really doesn't apply these types of training paradigms to their interventions that they apply. If you look at data in CVA, SCI, or TBI, patients, particularly in inpatient rehab, receive less than 500 steps per session. And in outpatient, they're around 500 to 1,000. If you look at the intensity that people work at during physical therapy in TBI, SCI, and CVA, over the past 20 years, patients rarely reach aerobic thresholds. So Jenny Moore did a study in our lab back in 2010, just asking, why do patients plateau? And there's a lot of potential reasons, but one theory was that patients just don't get the practice and the intensity that they need. So we actually monitored patients' activities and outcomes during the last 4 weeks of clinical physical therapy when the therapist identifying them as reaching a plateau. And we compared that to after they were discharged, they came to the lab and we put them on a treadmill and walked them at the same frequency, which is number of sessions per week, for 4 weeks of high-intensity treadmill walking. We gave them assistance at their legs only as needed, which is really one individual, and we targeted up to 85% of their heart rate max. So high-intensity, all walking practice, not doing anything else. And what we tried to measure was stepping activities. The step monitor is a very accurate pedometer, and it measures stepping activity throughout the day. If you wear it throughout the day, we really were focused on what they were doing during the physical therapy session. These green bars indicate what the activities were, and we also indicated what they did before and after outside of physical therapy type sessions. And what we found is that greater amounts of stepping practice with focus activities, only providing treadmill walking at higher intensities, led to far greater amounts of stepping practice than conventional therapy. And that led to greater outcomes. So here's mean steps per session. The black is clinical physical therapy. The gray is locomotor training. And there's a 900 to 4,000 steps per session difference in these populations. When we look at the changes of what they did outside in the real world, the mean changes in steps per day, they really didn't change much at all with clinical physical therapy, and they changed about 900 steps per day during following locomotor training. And that was a huge gain. And what this represents is kind of a dose response curve, like you see in pharmacology. So changes in mobility, steps per day, was related to steps per session. So dose here is this mean steps per session. Response is changes in steps per day. And there was a linear relationship between how much practice they got and how much they improved. Now, the actual correlation wasn't, it was certainly significant, but wasn't substantial. It's R is equals 0.6, which is good, It means that this is a significant contributor. It's not the only thing that matters, but it's an important thing. And we've seen this replicated in a few different studies. Again, emphasizing specificity and amount matter. So what about some other studies? So the LEAPS trial. Duncan, in the New England Journal of Medicine in 2011, published the LEAPS trial of walking versus non-walking, and there were no differences between outcomes. Well, we think that may have to do with something else, namely intensity, that they kept the heart rates purposely low, lower than 6-minute walk tests often that we see. What about robotic devices? They provide a lot of practice as compared to regular therapy. And those have failed somewhat. And the reason why is that studies in patients with spinal cord injury and stroke recently in 2018 show that exercise, oxygen consumption, and heart rates are lower during robotic PT as compared to PT assist as needed. So people relax when you reduce the heart rate purposely, or you put them in a situation where you're guiding the limbs. They don't do as much work, and that intensity is not as high. So intensity is a really still an important part. So when you put these principles of practice, you focus on specificity. You focus on repetition. You're only going to do walking training, and you're going to try to get a high intensity. The outcomes are good, but not great. Most studies have focused on the treadmill. So what people see after these studies that are listed is that you have gains in 6-minute walk often, but you tend to have limited gains in speed, balance, transfers, and steps per day across these studies. They're not consistent. So there might be something else that we can tap into. And so when we think about putting these principles into practice, we think we want to rethink these principles. So, for example, there may be an individualization that may be important. So Luis Ada and Catherine Dean in 2010 published studies related to subacute patients with stroke and how they actually improve better with treadmill walking than with overground walking. And so that's great. It might say that, oh, treadmill you really got to do, but maybe it was really due to the fact that they're all subacute and they all were non-ambulatory. Maybe it was easier to get steps. And for example, Stephanie Miller-Combs did a study in 2014 where she talked about overground walking versus treadmill. And in patients with chronic stroke who were walking, overground was better. So there may be an individualization that we need to consider. And maybe the actual task may be more important to people who are going to navigate real-world situations. So salience and specificity of task practice may be really important when those individuals who are ambulatory can actually negotiate real worlds. But what's in the real world? There's a lot of things that people have to deal with, such as walking on uneven, unstable surfaces, walking over obstacles, slippery surfaces, walking over stairs. There's a lot of variable, difficult tasks which require varied kinematics, varied tasks, varied environments that people have to deal with. So you take these principles of specificity, intensity, and amount, and you add in this variability, which tries to incorporate the salience. And there are some pilot studies that we've run in a small randomized trial where we've tried these principles, and here are some videos of 3 individuals. And the top 2 are fairly impaired. Their Berg balance scores are 5 and 7. And one individual is really impaired on getting moving, another individual is less impaired and more focused on balance. But you try to figure out, like, how am I going to provide variability and saliency and provide as much practice as I can to get them to do as much as I want and address their deficits. And the person on the bottom, I'll replay this video for you guys. He's walking at a fairly decent speed, and we're doing the same paradigm as we're only walking, we're doing high intensity, but we're really going to challenge the variability. He's not nearly as low level. He's about to be able to run, so we're going to challenge him as much as possible. Keep those heart rates up, challenge them to what they can do. So it's kind of a paradigm-based protocol, or paradigm-based intervention rather than protocol. Not everyone gets the same thing. And the data from these studies was presented in a small randomized trial, 2016, the very intensive early walking post-stroke, the BUSE trial, where the experimental group that got high-intensity training for the same number of sessions as the control conventional therapy group, there was threefold differences in self-selected velocity and 6-minute walk. And again, the amount of practice they received was related to how much they improved. We did another study, follow-up, and combined analysis for a few groups, and have done this in spinal cord injury, and what we see is that the same principles apply, that specificity, intensity, amount, all are really important. Walking training in variable contexts or forward is better than lower intensity. And what I'm not showing you here is that, and this is the very intensive variable ambulation training, the Vibrant study, 3 groups, high intensity variable, high intensity forward, and low intensity variable. High intensity is much better for self-selected and 6-minute walk, but functional gait assessment only improves in the high intensity variable training. This purple group really improved on balance, whereas just walking them didn't improve as much. And we've seen these type of results replicated in spinal cord injury for both intensity and amount in practice. So when you do these types of studies, when we talk about this at conferences, when we present it, when we publish it, when we articulate this type of information in the clinical practice guidelines published by JNPT in 2020, we get a lot of pushback. And the pushback is about a lot of different things. It's related to how we're doing things, traditional interventions, how we're very much different from what other people are doing. And it's interesting because I want to show you some of the video and audio of some of these interactions we've had at these conferences. It's pretty enlightening.
Excuse me? You can't be serious, man. You cannot be serious! I mean, come on, Ed, it's bullcrap.
I got something for you to read right here.
Mississippi Copper, what's that?
It's a little insane, right? So what I'm trying to give you now is some ammunition really to try to defend yourself when you may try to do this in the clinical setting. The pushback is specific sometimes, and we'll hear some references to push back against that. So therapists often say, there's an increased risk for patients. There's increased cardiovascular stroke risk. Well, there's actually no increased risk for these types of interventions above conventional therapy. There was a meta-analysis by Marco Pang, and then a number of cohort and randomized trials that have shown there's really no increased risk. You're ignoring their impairments, people often tell us. They're not ready for walking. Well, what we find is that when we address variable task practice in our interventions, strength balance transfers, which we don't really focus on, improve with high intensity training in variable context. And there's a number of studies there, including the data by Susan Horn in 2005. One common comment is that therapists say that patients' gait patterns look horrible and you're reinforcing bad habits. So this is the distinction between performance and learning. What we see in our studies, and there are a number of references here, that there's greater improvements in paretic limb kinematics and kinetics of high-intensity trainings. Even if we're challenging them and making them work hard, really, by definition, they're going to look bad. We don't really care what they look like during therapy, and that's not really reinforcing bad habits. It's what they look like after therapy, what they've learned. And that's where we see the really great improvements in motor control, coordination, that we've published in these studies. All right, so when you think about applying this in inpatient rehab, and the rest of the speakers are going to talk about that, or in inpatient, outpatient, geriatric, home, these are the things that you have to consider. And in a research study, we really like our criteria for inclusion in our protocol. But in clinical studies, there's a different criteria and protocol. We kind of include everything. So you're kind of navigating the difference between moderation on the research and crazy town, where you're going to take all comers. So we actually have some data on all comers. in the inpatient rehab setting, which is somewhat of a hot mess. I'm not saying that everywhere else is a hot mess, but there's a lot of chaos in that stuff. So we think about what does the research do, and we try to think about what can we do clinically. And so what the research does is able to apply about 2,500 to 3,000 steps per session. It really depends on level of impairment. And clinically, we can't do all days walking training because we have to do outcomes. So we're looking at about a 500 to 4,000 steps per session, depending on level of impairment. Really low level, total assist, moderate, max assist, they're not going to get a lot of steps. We're trying to achieve high intensities. For those of us in the lab, we're able to get about 50% in the heart rate zone and about 90% RPE zone. It's really hard to get in the zone with greater impairment. So we're doing the best we can. The goal is to get as much as you can. And if you can't get in the zone, you got to keep on trying with the next session. Variable difficult stepping practice, we definitely try that. We typically have higher level patients in research studies, but in the lower level patients who are total or max assist, you may just try to be getting in the ballpark, just trying to get the steps in as much as you can. You may focus more on the treadmill, less on the variable type task practice. So strategies to mitigate barriers and relative efficacy. Jenny is going to talk about this in a second, but the strategies are if you're going to do this, you got to get all PTs on board, all prioritize walking and perform outcomes, which is what we did in a couple studies. If you do that, OT and you want to incorporate everyone else because they'll feel left out. OT and nursing, we tried to incorporate them. OT was going to say, okay, you know what, you're going to focus more on walking. We're going to focus a little more on transfers. And there was some articulation that they would try to do that. And then nursing, it's really important for the therapist to be able to get the full hour of therapy, which means that nursing hopefully will be able to get the patient ready for therapy on time, which means they're dressed or ready to go at the start of therapy, and then the therapist doesn't have to spend time getting them dressed. I know that's crazy talk, but we try to do that, and then we're able to do that successfully in a couple of places. We had therapist aides in a couple of places to assist stepping under PT guidance, and administrative and physician support for scheduling and medical complexity. So as far as efficacy, we did a pilot cohort in 200 patients in 2015. And then Jenny did a study in 2020 using a Norwegian group, a couple of groups, where she did usual care for 1 year and just called that pre-implementation, and did high-intensity training post-implementation, measured that for a year. And what we see is that patients post-stroke are able to improve dramatically in the rate of gains for walking outcomes. This is length of stay for the 3 locomotor outcomes. This is selective velocity, fastest velocity, and 6-minute walk. And Berg is over here, but the rate of gains early on were substantial in the first week, and they kept on improving. They were significantly different at discharge, or the same about 3 weeks into it. And then for different reasons, the patients were able to maintain their length of stay for longer in the post-implantation, and they made much larger gains. But regardless, that 3-week change, significant differences in all groups. In the Berg, there was actually no difference at the first week and no significant difference, although there was a small difference, but it was not statistically significant. There was really no difference, but we didn't practice that in inpatient rehab with the high-intensity training. So it means it's not sacrificed, and the Berg continued to improve as they went forward. So this is generally the overview of what you can do and the idea that it can be applied to inpatient rehab. I know Jenny is going to talk about barriers and facilitators to implementation.
Hi everyone, I'm Jenny Moore. Today I will be presenting on barriers, facilitators, and strategies to facilitate implementation of high-intensity gait training in clinical practice. Before I get started, I'm going to quickly make some disclosures. I am the advisor for the Regional Center for Knowledge Translation and Rehabilitation in Oslo, Norway. I'm also the founder for the Institute for Knowledge Translation. The information that I'm presenting today is guided by the knowledge translation research, but it also reflects our experiences with implementing high-intensity gait training into clinical practice in several clinics in the United States and Norway. While many barriers, facilitators, and strategies are dependent on the context in which high-intensity gait training is implemented, I will discuss the ones we frequently encounter. So why is identification of barriers important? Knowledge translation research indicates that knowledge translation efforts may be more successful if barriers are identified and targeted with strategies to overcome them. So basically, identification of barriers should guide implementation planning and strategies. Barriers exist on multiple levels. The figure on the slide was published by the developers of CFIR, the Consolidated Framework for Implementation Research. The CFIR provides a menu of constructs arranged across 5 domains that can be used in a range of applications. One way to use CFIR is to guide a systematic barrier assessment. From this perspective, this slide demonstrates that barriers can exist at the following levels. The outer setting, which includes factors outside of the department or facility that is implementing the intervention. The inner setting, which includes factors associated with the department or the facility that is implementing the intervention. The individuals involved, which includes the clinicians, the leaders, the patients that are directly involved with the implementation project. The intervention itself. So what are the key attributes of high-intensity gait training that may make it more difficult or perhaps more easy to implement into clinical practice? And then lastly, the process used for implementation can certainly be a barrier or a facilitator as well. Because we have limited time, I'm going to focus on barriers and facilitators and strategies that are related to the intervention and the inner setting. So I'm going to start with the barriers related to the actual intervention, high-intensity gait training. We often hear clinicians wonder if there is an advantage to using high-intensity gait training. They wonder, is this better than what I already do? They know that patients typically get better in inpatient rehab and in outpatient, so why is change needed? Is this going to be more efficient, more effective? And so clinicians are wondering what is the relative advantage for doing high-intensity gait training over other interventions. The complexity of high-intensity gait training may also make it more difficult to implement into clinical practice. It's substantially different from traditional practice, and it requires a shift in delivery of care, as well as learning how to actually deliver this intervention in clinical practice. This could be a lot of work. High-intensity gait training may also require purchasing of some new equipment, such as heart rate monitors, and this may come at a cost. So as I mentioned, barriers should guide the selection of knowledge translation intervention. So on this slide, I have the barriers we just discussed, relative priority, complexity, and cost. And then I've added some specific strategies that might help overcome some of these barriers, and I have some examples on the following slide. For relative priority, or wondering if the new intervention is better or should take priority over current interventions, it may be helpful to start with implementing a core set of outcome measures to assess the outcomes of your patients with usual care. This will also provide another metric other than experience to help identify changes that result from your intervention. For the barrier of complexity, simplifying the new practice and providing tools and resources may be helpful. I have some examples and suggestions on the upcoming slide. For costs, identification of low cost and valuable tools is helpful. I have some examples of these as well. With high-intensity gait training, the research demonstrates changes in gait speed, walking distance, and balance result from the intervention. So it is important to pair this particular intervention with outcome measures that assess these specific constructs. The clinical practice guideline on a core set of outcome measures for neurologic physical therapy recommends the 10-meter walk test for gait speed, the 6-minute walk test for walking distance, the Berg Balance Scale, and the Functional Gait Assessment for balance, and many people also like to use the Mini Best Test for dynamic balance. In our projects, we almost always pair these measures with high-intensity gait training to determine whether patients are making progress as expected from the program. We can also use some of the information gained from these measures to predict potential outcomes with high-intensity gait training as well. We also recommend that these measures are administered at admission and discharge and in between as much as possible. So in inpatient rehab, we also do weekly measures as much as possible. And in outpatient and other settings, we also recommend interim measures. We also make very specific recommendations for the high intensity gait training dose that we're trying to implement using the FIT guideline. This is often adapted by each site so that it's feasible to achieve, but the clinicians try to keep the dose as similar to how the intervention was studied as possible. Most inpatient rehabilitation sites choose to implement high-intensity gait training at the dose listed here on this slide. A frequency of 4 times a week because they need 1 time a week to do their outcome measures and do family training and any kind of home exercise program training that they're doing. An intensity of approximately 75 to 85% of heart rate max. The time, as much time as walking as possible in a 1-hour session. And the type, they often adopt the high-intensity variable gait training program, which is defined in an appendix published by Carrie Halloran and George in 2014. Outpatient sites vary from this dose depending on how often patients come, and often they are influenced by insurance as well. But I highly recommend setting forth the specific dose that you're trying to achieve and really striving to achieve that specific dose as you implement high-intensity gait training. To overcome another barrier related to complexity of high-intensity gait training, it is helpful to develop tools and resources to support delivery of high-intensity gait training. Here are some examples from our projects. We have some lanyard tags here that you can see. This one shows the RPE scale, and this is a heart rate calculator. We have those that can be attached to these can be attached to name tags, but then we also have some signs that can be attached to the wall with this information as well. Since heart rate is such an important part of high intensity gait training, we need to be able to quickly calculate the heart rate zone as well as monitor heart rate. On this slide, there's an Excel sheet calculator that clinicians can quickly plug in the patient's heart rate and whether the patient is on beta blockers, and the calculator will provide the heart rate range. We also have various devices that we use in the gym to measure heart rate. These include pulse oximeters that we often see in physical therapy gyms with forehead and ear sensors, as well as polar monitors that sync to iPods to more easily monitor the time in the heart rate zone. For the iPods, we often purchase refurbished ones from Apple if they are available to reduce costs of the equipment. Since we are moving around with patients in gyms and hallways, we need easy ways to carry the heart rate monitors. So for this, we found commercially available equipment such as cell phone holders that can be placed on the physical therapist's arm, on their lanyard, and in other places, and as well as on the equipment to make it easy for the clinicians to monitor the heart rate while providing the high intensity gait training. Equipment to do overground gait training is also very helpful, but it's not absolutely necessary. We identified some lower cost devices such as the Riften tram and sailing tracks that do not provide body weight support. We also often use lower cost devices that are associated with agility training in athletes for variable training. These include weighted vests, leg weights, hurdles, and agility ladders. Protection of joints is very important during high-intensity gait training. We recommend having several low-cost, off-the-shelf orthotics and braces in the gym. We've also numbered them so that you can easily document which device a patient is using and retrieve it before training. For example, the right PLS seen here might be labeled number 2, and when Mr. Smith is coming to PT, I can grab PLS number 2 before treatment. One last thing to note is that high-intensity variable training is often associated with many different devices such as weights and obstacles, and it's very helpful to gather everything you need for one patient at the beginning of a treatment session so that you don't have to run back and forth and grab things from different areas in the gym, and it'll help you maximize the time providing gait training with your patient. Now that we have talked a bit about some barriers related to the high-intensity gait training interventions and strategies to overcome them, now I'm going to talk about some barriers associated with the inner setting, which is the department or the facility where the intervention is being implemented. The intersetting barriers that we commonly work to overcome include culture and norms of a facility. These often include usual care practices that are standards of practice at the facility. These can include neurodevelopmental treatment or BOBATH treatment, PNF, and neuroIFRA. Less intensive interventions are also provided, and often clinicians deliver multiple interventions in one physical therapy session to address gait. Facilities also have an established workflow, from scheduling of patients and how the interdisciplinary team works together to how the clinicians fit in documentation time. Implementing a new practice can disrupt all of these cultural standards and norms within a clinic. The implementation climate can also be a barrier or a facilitator. Factors that contribute to implementation climate include the clinicians and the organization's readiness to change and receptivity of the individuals involved in the project. An important related concept to understand is de-implementation, which is the removal of interventions that do not appear to provide optimal care. Frequently, many interventions are provided for the purpose of improving gait. Here's a pie chart of one of the clinics in which we implemented high-intensity gait training. You can see there are several different types of interventions provided, all for the goals of improving gait in patients post-stroke. However, we know that neuroplasticity occurs with high amounts of repetition of walking, and with high intensity gait training, we need a whole lot of stepping and high aerobic intensities. So when implementing high intensity gait training, we really need the pie to look a bit like this. In order to implement with fidelity, we need to make time for these new practices, which means that we need to de-implement or actively let go of the ones of lower value. Some strategies that may help with de-implementation include gaining stakeholder buy-in, and one way to do this is to set up meetings to get the group to come to consensus that implementation of high-intensity gait training is important for the organization and for their clinical practice. In a successful high-intensity gait training implementation project that we did in Norway, the group did exactly this. Before deciding to participate in the implementation project, the clinicians and the clinical leadership met regularly for 1 year to understand the high-intensity gait training research and its application to clinical practice. During this process, the clinicians reached a consensus that high-intensity gait training should be implemented into clinical practice, and they committed to making this change happen. They also believed the organization could make the change. When the project's implementation component started, they set a date to stop the other interventions and replace them with high-intensity gait training. The group also held each other accountable through discussions and informal audit and feedback. It is a great example of how gaining stakeholder buy-in can facilitate successful implementation. Another strategy is to provide education and training on the benefits of high-intensity gait training and unusual care interventions that are being provided within that clinic. Hopefully, during the process of going through all this literature, it can be identified that high-intensity gait training may have potential to improve outcomes and may convince the group to at least give it a try and practice. Leadership support can also help with de-implementation and implementation efforts, and I'll talk more about this in the next few slides. Now, the knowledge translation research on implementation leadership indicates that leaders can positively or negatively impact adoption. It's in one review article, it was found to be the only significant predictor of the use of guidelines, and in many studies, there have been significant associations between adoptions and behaviors of the leaders, including involvement in the project, attitude and commitment to change, style of leadership, and their vision. So what can leaders do? Well, leaders can have actions that facilitate adoption, like giving the clinicians time to learn about the new project, putting resources behind purchasing equipment and supporting the clinicians and getting what they need to be able to deliver high-intensity gait training. Leaders can articulate the importance of the knowledge translation initiative. They can say high-intensity gait training is important to our organization. We think our patients are going to have better outcomes, so we need to figure out how to make this happen in the clinic. Visibility in the clinical practice setting is also helpful. Having leaders walk through the gyms and look around, see how high-intensity gait training is being adopted can also be very helpful. If they can provide direction, resources, and support, monitor performance and outcomes, so looking to see whether clinicians are adhering to the recommendations and providing feedback about whether they are. And then lastly, revising policies and processes to include the practice. So this includes job descriptions, it can include performance appraisals, and so forth. So I'm going to give you an example from one of our high-intensity gait training projects. This was implemented in 2015. In this organization, the leadership, the CEO actually articulated the vision that in this particular facility, we needed to integrate research and science with clinical practice. And so then the CEO worked with the director and the managers to set the expectations for the staff. And then as they hired new clinical staff to come onto the floor, the clinicians knew that's what they were expected to do. They were expected to embrace these new interventions, these evidence-based interventions. And the managers discussed with the clinicians their individual goals related to the vision and integrated those into performance appraisals. Now, the manager on this particular unit was actually a speech-language pathologist. And during treatment time, she would walk around the gym to look to see whether the patients were getting high-intensity gait training. Those that were, she asked them about it. She asked how they liked it, about their satisfaction, if they felt like they were getting better, and so forth. When she saw that clinicians weren't delivering the practice and she thought the patients should have received it, then she questioned why. She wanted to find out from the clinicians what the barriers were so that she could help them overcome them. She scheduled times for case discussions so that the staff had some time to come together around discussing the application of high-intensity gait training. She incorporated expectations into performance appraisals and required that the clinicians reported on high-intensity gait training during team conferences. So again, this is a great example of how leaders can really promote adoption of a new intervention, and specifically in this case, it was high-intensity gait training. Okay, well, that wraps up the barriers, facilitators, and strategies to implement high-intensity gait training. I would be happy to answer any questions. Please feel free to reach out.
In this talk, I'll be presenting on how we translate these strategies to push high-intensity activity for older patients. In general, the features that distinguish an older adult break down into slow and low, slower movement, slower responses, lower levels of physical activity, lower stature. Every system of the body is affected by aging, and pretty much every system reflects this slow and low process. Overall, then, we have a movement system with aging that has slower responses and lower output, which impacts the ability to move efficiently and effectively. Specifically with aging, gait is influenced by altered biomechanics and disrupted motor control, with both age-related and pathologic changes in the musculoskeletal system and in the neurologic system impacting gait, with timing, coordination, and sequencing issues affecting efficiency and effectiveness. As gait changes with age, we see increased variability, decreased balance characterized by increased time and double support and a wider base of support, and decreased pacing. Speed noticeably declines with aging, such that in advanced age, there is a greatly reduced difference between a person's usual speed and their fast self-selected speed. So the impact of this becomes noticeable in community ambulation. The person's ability to speed up to cross a street before the light changes, adapt to different paces in crowds, and modify their own speed to meet environmental demands becomes reduced with advanced age. And so older adults often restrict their community mobility because they don't have the ability to have a usual speed and a fast speed. Usual and fast become about the same, and that impacts their ability to walk in the community. So given these issues, it seems logical that walking speed would be an ideal therapeutic target for reducing disability, dependency, and improving physical function among older adults, and in particular, older adults with various degrees of frailty or disability. The question that sort of gets asked then is that if we have this robust body of research that supports the benefits of high intensity in younger populations and in populations with disease, does this work for older adults? And is it safe for this population given their high prevalence of multiple chronic conditions? We know that there's a normal decline in VO2 max in the realm of about 10% per decade, which really provides that piece of evidence we need to address this change to help maintain physical function, because this is a normal age-related change. The other issue is that we know that for VO2 levels below 18, there's a reduced probability of being able to live independently, and that even our most basic ADLs have these VO2 demands that might come closer to the average VO2 levels found in frail and non-frail older adults. The end result of this then is that the basic ADLs or the instrumental ADLs that we're asking patients to complete may become more like max exercise tests for them given their levels of deconditioning and frailty-related changes. So importantly, older adults are amenable to change. And if VO2 declines with aging normally, it worsens with pathologic aging of frailty, we want to think about exercise interventions that might be able to slow that decline or actually even reverse those changes. And so in this kind of hallmark study, looking at octogenarians, VO2 peak and cardiac output improved after 6 months of exercise training, and it declined in people who were in the control group who did not participate in any exercise. So this was really one of the first studies that helped to dispel this belief that older adults can't improve with training. And in fact, they can, and we can make significant improvements in their capability and what they're able to do. So the focus of our research has been in this area of high intensity for more frail populations. And what we've done is really try to adapt the work that George Hornby and others have done and adapt and modify it for older adults in assisted living and independent living. Notably, our work is all done in the community level. We're not bringing people to a lab, so we're doing it in their retirement home with the equipment that they have in the home, which basically is nothing. So we work on very similar tasks: stair climbing, walking on compliant surfaces, gait without assistive devices, weighted walking, and walking in multiple directions. And we use the similar goal of George's work, 15 to 17 RPE, or greater than 70% heart rate reserve. Our pilot data has shown that after only a 12-session, a 6-week-long intervention for assisted living residents, there are significant differences in frailty levels, fast walking speed, 6-minute walk test distance, and the Berg balance. We also found a 17% increase in daily stepping levels measured during a 1-week observation period at baseline at the end of the intervention. So recognizing that any increase in ambulatory activity is positive, 17% represents a meaningful improvement in lifestyle physical activity as a result of this intervention. So we're really thinking that high intensity gives people the capability to do more, and having that capability can motivate them to be more active. So how do we do this? Well, first we calculate the target intensity that we want people to walk at. Gait training should be intentional and purposeful. There's no gait training that's simply walking down the hall. And so as illustrated in this comic, it shouldn't be that our patients are walking and we're not doing much. If we're truly pushing our patients, we as the PTs should be working hard too. So don't be afraid to break a sweat. We use the Carbonin formula to calculate target heart rate intensity. Of note is the formula to calculate heart rate max, and this is different than the conventionally used 220 minus age, which is far less accurate, particularly as people get older. The general principles by which we want to approach training include increasing the difficulty of tasks and really challenging people, using variable tasks, and promoting a high volume of stepping activity. In one of our studies, for example, participants on average walked 1,680 steps per day. However, during the 30-minute walking session, they averaged 850 steps. So roughly half of what they were getting in one day on their own was what we pushed them to do in 30 minutes. So get people moving, consider active rest breaks where people maybe are walking but at a slower intensity so that they're getting that stepping in so that we can push a high volume of walking activity. One of the first things we do in our training is get rid of assistive devices as much as possible. We've all probably seen the person pictured here, extensively weight-bearing through their arms on their walker. We get rid of assistive devices in training so that people can't use their arms to unload their legs. And if needed, we use a handrail, which is commonly found throughout the retirement communities, but we really try to get rid of people's devices as much as possible. We work a lot on uneven surfaces. And we do not start with flat surfaces and work our way up to uneven in this like kind of pre-gait to gait thing. We just start with gait. We get people walking. We start them with the hard tasks. We start with uneven indoor surfaces and challenge people because if they can do that, level walking is going to be a breeze. Here we see an assisted living resident. We've gotten rid of her walker. And so this is at session 3, and you can see her kind of using the handrail a little bit. She doesn't feel very steady. She wants that kind of crutch for building her confidence. By session 6, now, we can see some noticeable improvements in her steadiness. She's not reaching out for that handrail anymore. She still is walking a little bit more tentatively and slower with a decreased stride length. But we can really see some noticeable differences just between session 3 and session 6 in getting rid of that walker. And here by session 9, she's able to walk much more confidently without an assistive device, without the rail, and we start to see that longer stride length. She's starting to self-select a much faster speed. We also do a lot of variable tasks. So I like to personally look at sport drills like dribbling in basketball, foot drills in soccer, and use those same patterns and do changes of directions to really train our patients in the way that athletes would prepare. So for older adults, the research shows that a cadence greater than 100 steps per minute is needed to achieve a moderate intensity. So that means people need to walk fast or faster than they normally walk. Our standard prompt is walk as fast as you safely can. We provide this reminder to people when we notice that they're slowing down, and we really go out front and set the expectation and make speed intentional. It's not just let's walk down the hall, but rather I want you to walk to this point as fast as you safely can. We know that people will do this in the clinic, but usually they're not going to do it at home. So our purpose of training is sort of twofold. We want them to get better, but we also want to try and reestablish some habit formations such that the self-selected speed they pick is faster because they've been trained to walk more quickly and they now have a new habit that has been ingrained in themselves. To increase speed, we've used a metronome to establish cadence. We converse, and if people are talking easily, we alert them to this and encourage them to pick up the pace. And lastly, sometimes using the treadmill to establish a fixed pace. But in general, we really try with the older adult population to focus on overground training and not treadmills as much as possible to really make this as functional as can be. In general, we start with the hardest activities first, which for older adults seems to be stairs. So there's this bit of carryover effect from having elevated heart rate. And from a safety perspective, I sort of want to do the stairs a little bit more when they're fresh in the session. Finally, as we're, targeting this 15 to 17 RPE, we do need to monitor vitals because especially with older adults who are maybe untrained or not used to having kind of a background in any kind of vigorous activity, they will report higher RPEs that don't necessarily match their heart rate responses. So this is something we're seeing in our data, that people will tell us they're working at an 18, but their heart rate doesn't really necessarily match that. So we use heart rate to provide feedback to the patient that they do have capacity to work harder and more quickly. I'd be remiss without mentioning safety. So pushing intensity may increase the risk for falls during the session, but it does promote better cardiovascular health and mobility outcomes. So this is something that we have to weigh as clinicians. To minimize risk, there's some very simple strategies: gait belt monitoring, wheelchair follow, etc. One thing we've learned is the importance of language. High intensity for older adults often seems off-putting, particularly to physicians, retirement community directors, patients, children. And because of frailty, deconditioning, and age, high is sort of a relative term. So positioning this form of training as effortful training or targeted mobility training might be a little bit more palatable for those stakeholders. And then for you as PTs, it can sort of seem scary to start pushing intensity with an older person who appears more fragile. We want to start maybe our practice with less involved patients. We need to practice these techniques and determine what the training intensity is going to be before beginning treatment, so you sort of aren't on the spot trying to calculate that. And really through practice, you can challenge your misconceptions about what older adults are truly capable of doing. So thank you for your time. Please don't hesitate to reach out with any questions you might have about how we're implementing these techniques for older adults.
Welcome everyone. My name is Carrie Halloran, and today I'm going to be using a patient case to highlight how we can use data to drive clinical decision making. And we'll also spend a little bit of time talking about how you can change your clinical practice or perhaps support the change in your clinical environment. Before we begin, I'd like to acknowledge my disclosures. I am the co-chair of the Knowledge Translation Task Force for the Clinical Practice Guideline to Improve Locomotor Function. I am also a faculty member at Washington University, where part of my time is supported by National Institutes of Health Research grant for a project separate from what I'm going to be talking to you about today. So hopefully at the end of this presentation, you'll be able to start to integrate your examination and your outcome measurement results into your clinical decision making. And I hope that you can compare your current clinical decision making to what we would consider to be evidence-based clinical decision making and determine if they're aligned or not. And perhaps they're malaligned. Maybe how you practice, how you make decisions is different than what we've talked about throughout these 4 parts of this Removing the Kid Glove talk. That's okay. We're going to talk about how you can identify initial steps to change your practice or to promote that change within your clinical environment. So first, we're going to start off here with our patient case, a little bit of a description. So this was a gentleman who had a right posterior frontal and internal capsule infarct 10 days prior to his admission to inpatient rehabilitation. He also had a diagnosis of hypertension, diabetes, chronic low back pain, congestive heart failure, coronary artery disease, non-ischemic cardiomyopathy, and had a defibrillator placement in 2015. So first, from a body structure and function perspective, he had zeros and ones distributed throughout his left lower extremity strength. He had absent light touch and proprioception and impaired cognition. From an activity perspective, across outcome measures and within the functional independence measure, his initial BERG was a 5 out of 6. The therapist was unable to test the 10-meter walk or the 6-minute walk. He was unable to take any steps, so 0 feet for total assistance with his walking. They were unable to assess stairs, and for transfers, he was max assist. For participation, though I don't have these measures to report, remember you can assess participation measures. This is an example of one that's recommended by the Stroke Edge Group, the Stroke Impact Scale. From an environmental consideration, he did have 4 steps to enter his home. He did have the ability to live on a first floor level, and he did have meaningful transportation and a family member that could drive him to therapies post-discharge. This gentleman was motivated for therapy. He had supportive family members, and his real goal was to return home with independence. So it means that walking is really important. So when we take these baseline examination measurements and our outcome measurements, we have decisions we need to make. First, we need to think about the future. Where do we anticipate this gentleman being on discharge from inpatient rehabilitation? And what does data tell us? So we know that the Berg balance score is highly predictive of ambulation and discharge from inpatient rehabilitation. And what we really know is that the sensitivity for the ability for the Berg balance to predict outcomes after 1 week of a high dose intensity gait training is highly predictive. And we know that a Berg score of 10.5 during the second week, again, when this individual has received high dose, high intensity, repetitive stepping training, it's indicative of developing the ability to ambulate at contact guard assist or better. We know that baseline strength is important, so the volitional strength is important in predicting outcomes. But what we also know is that the dose of stepping matters, and we can move that needle. And so now as therapists, we're treating this individual who's highly dependent, has a Berg of 5 out of 6. We have some choices. We have to select an intervention. So we could go off conventional wisdom. We could have the notion that we need to sit before we can stand. We need to stand before we can walk. We have a variety of tools in our toolbox. We have this notion, this historical perspective that kinematics matter, and that we should heavily guide. And we have another choice also. We have the choice of maximizing the active ingredients that George has spoken to you about, and deliver a high dose of high intensity gait training to see what happens after this first week of repetitive stepping training. And so that's what we did in this case. So the goal, if we think about our FIT guideline, if we think about what ideally does research and literature tell us that we should be doing, first is a frequency of at least 4 times out of the week. For this individual, this patient case in specific, when we want to exercise up to 70 to 85% of the heart rate maximum, that means our target range is 117 to 133. We want to get as much time as possible in that 1 hour session. And the type of activities we want to prioritize are high intensity variable weight training. We can do it over ground, we can do it on a treadmill, and we can do it on the stairs. And so here is an image of him walking in the beginning with his therapist over ground. You see he's receiving a little bit of upright posture and stance control. He's having a really hard time with his lateral and sagittal stability. The therapist is giving him a little bit of assist for limb swing. He's got a hemi walker that gives him a good amount of support, both in upright posturing and in that lateral and sagittal stability. You see, it's really hard. You see, he's a little bit hesitant. You mentioned he has some cognitive impairments, some low back pain. And this is something that you're going to have to work through. Not only yourself as the therapist from a physical assist perspective, but also the patient. This is not going to be easy. It's a lot of hard work. Let's take a look at him on the treadmill. So here he is on the treadmill, receiving some body weight support for stance control, upright posturing. The therapist is giving some limb swing assist. He's using his hand also for some lateral and sagittal stability and likely to some help for upright posturing. So it's a lot of hard work. Again, continuously monitoring the heart rate, working towards targeting that heart rate range. So over the first week, it's important. So we started with our goal of we want to do at least 4 times a week, targeting heart rates of 117 to 133 beats per minute, as much as possible as can be achieved in an hour. And we're prioritizing high intensity variable weight training. So what were the therapist and the patient able to do together? So what actually was delivered? So they were able to deliver 4 sessions in the week. The intensity was 12 to 15 on a rating of perceived exertion. They were not able to achieve the heart rate zone due to fatigue and some limitations of hypotension. The time the patient would tolerate per session was about 7 to 20 minutes. And the type of activities that they did was both over ground, treadmill, manipulating the biomechanical subcomponents. The patient did wear a left air cast for lateral anchor support. And as you saw in the video, a Give More sling to make sure he had shoulder protection. So this is our opportunity. We can take the goal fit and we can compare it to the actual. And then we think about what are those barriers that we had so that from that actual fit, to what we wanted to do. We really have to assess, in this patient case, what was limited. Were you set up in an appropriate amount of time? Did it take 25 minutes to get the harness on? Did the patient need some time to put the air cast on? How can we use the interdisciplinary team, family members, and the patient to have that patient ready to go to maximize that hour? Maybe you're not as comfortable or familiar with the equipment. Maybe you need to work with your PT team to be comfortable with the harness and the heart rate monitor and managing all at one time. Maybe there are patient-specific barriers. Maybe he's really tired. Maybe he's got hypotension. Maybe scheduling in the morning isn't as good as scheduling in the afternoon or vice versa. So you really want to take a look at what you're able to deliver and how it compares to your goal, and problem solve after each session how you can make those two things more aligned. And so here are the outcomes after 1 week of high dose, high intensity step-in training. So pay particular attention here to this first outcome of the Berg Balance Scale. You see the patient started at a 5 and jumped to an 11 out of 56 after the first week of training. And what data tells us is that a Berg of 10.5 during the second week of treatment is indicative of ambulation of contact guard assist or better by discharge. So we see that jump in Berg balance. We see that response to treatment, and that tells us to keep going. So after the second week, so we've treated him, we've measured our outcomes. What are we able to deliver within the second week of training? We see that we've been able to deliver 4 times a week, and the patient's now getting up to 120 beats per minute and an RPE of 17. We've increased the amount of time, so 20 to 30 minutes. The conditions of gait training that he was able to participate in was some incline training. We've reduced body weight support to about 10 to 20 pounds. He's working at speeds upwards of 1.0 meters per second. And again, we're still using that air cast to give more for lateral ankle stability. And so after each session within that second week, we should be participating in the same type of activities. How does our actual fit compare to our goal fit? And it should be a continuous quality improvement because every patient is different. Every patient has unique barriers that we have to problem solve and work in a coordinated fashion with our interdisciplinary team, with that patient and with their family member to maximize their outcomes. And so here we are after week 2. We see, again, a great jump in his Berg balance. We see his gait speed has improved to 0.5 meters per second, and he's only requiring an assist. 6-minute walk test has improved to 170 feet. Min assist for walking and transfers, and 12 stairs with min assist. So we're making great improvements. And so let's take a look at his outcomes at discharge. So again, this gentleman started at a 5 out of 56. At admission. So basically he could sit on the edge of the mat. And we see at discharge, his Berg balance score is now 48 out of 56. His gait speed is 1.1 meters per second. He's able to walk 1,152 feet, 28 steps with modified independence, so huge improvements. So let's take a look at what he looks like over ground at discharge. So here he is working on a lot of activities with gait that challenges lateral and sagittal stability, negotiating this ladder on the ground, working on his timing and coordination within the context of gait. And here we see him on the treadmill, walking up an incline, has some weight resistance to make things harder, and just doing a really, really nice job. So I hope we've highlighted here today how we can use data to guide our decision-making that may differ from conventional wisdom or what we've learned previously. And perhaps today you have taken a look at your practice, and throughout the course of this, you know that there's some differences. There's perhaps some differences in how you analyze making decisions within the clinical environment. Perhaps there's some differences in how you would deliver interventions for an individual who's very post-acute stroke. That's okay. If there's differences, that's okay. Just because we did something yesterday doesn't mean we can't do something different today. And so I encourage you to take a look. What are your barriers? What are your facilitators that you have going not only within your clinical practice, but in all the settings that Jenny Moore has talked about previously. Identifying those barriers, maximizing those facilitators, and really working to make change happen. What if it's on an individual level and a clinical environment level? You have some opportunities. There's a lot of practice resources within the AMPT as part of the Knowledge Translation Task Force for the Locomotor Function CPG. Maybe you could start a journal club and you could read some evidence relating to some of the things that we've talked about here with you today. Maybe there's discomfort. Maybe you lack self-efficacy and the skills to actually make this intervention happen. That's okay. You got to try it out. Practice with your colleagues and try it on patients. With every patient, I am learning something new. I am trying something different because that patient is unique within this intervention, and that's okay. Don't give up. Use the tool of evaluating what your targeted fit is and what you were actually able to deliver. It gives you a nice test and gives you a footprint for how you can look at some of the barriers to making that actual fit look more like your goal. And remember the active ingredients. Remember that the type of test and practice that you do matters. The dose matters. The intensity matters. And we know that walking is really meaningful to our patients, important for health and wellness, and is related to where they go upon discharge. Thank you guys so much for your time and attention. If you have any questions, please reach out to any one of us, and please use the resources available to you through the Academy of Neurologic.
All right. Well, thank you all for a great presentation, great series of presentations. I know that we have quite a few participants. We have quite a few participants in the session, as well as quite a active question and answer